I'm speaking about adult scoliosis. Dr. Xu has spoken about pediatric scoliosis, and of course, we have spoken about the alignment of the spine, which is physiological and normal. Yes. So we see scoliosis in two populations, the pediatric population, and then we have the adult population. And there is a subset of people who had scoliosis in adolescence, and now they are adult and they may have had progression. But frequently we also see adults, especially the older adults, who have developed scoliosis in their older age. And like we answered the previous question, osteoporosis can sometimes also cause a collapse of the vertebrae, and if that's asymmetric, then that can also lead to scoliosis. When we are born, we are normally kyphotic, and then when we are a toddler, we are more lordotic. But as we grow older, we become progressively more stooped over, and that is a normal function of aging. We find that the female population has a slightly greater kyphosis as they, throughout life, and especially as they grow older. We also know that there is a large segment of the population which is now can be called elderly, and people are living longer and they have an increased functional demand. And this is something that we are all seeing more and more often with people who are now older but are more active. They are usually at work for longer. And scoliosis, which is especially in the elderly, which comes on later in life, can be problematic. So as we grow older, our bodies change. There is an aging process. The aging of the disc leads to the discs being narrower and less strong, also less supple. And that causes a shortening of the anterior column. The bones themselves are more osteoporotic, so the trabecular framework is more sparse and the amount of calcium per cubic millimeter is less. So the bones themselves are less strong, and with the demands of life over the years, we get collapses at both levels. The ligaments and muscles also show some atrophic changes as we grow older, and the spine essentially is less stable. Therefore, if there is a propensity to have a deformity, it becomes more and more problematic as we grow older. And we all know that as we grow older, we are more and more stooped over and kyphotic. In the elderly population, there are multiple areas where pain can come from, because patients in adulthood normally present with pain. And it can be from the structures of the spine, can be the muscles. And some people, as you know, have different sensitivity to the somatic input, or a different susceptibility to pain. The role of the physician is mainly to evaluate them. Reassurance, I find, is quite useful because most people are able to cope once they know what is going on. And the main aim is to have symptom relief and return to the normal activity for that age. And sometimes they need to be referred. Now, back pain, there are a lot of people who talk about back pain, and the Reader's Digest group, which is, I think, the main reading population, is the elderly. They have various ideas about what will help their back pain. And there are many snake oil treatments out there, but they don't usually work. And I think the importance, again, is patient education, which is something which you will see firsthand every day in your clinics. The options for somebody who has back pain, especially if they are older or elderly, is to let them rest and then slowly mobilize the muscles and exercises, sometimes traction. And these help people build up their muscles because they have been aging as well, and a strong core tends to help their back. As you grow older, the muscles are weaker, and they do need to be really activated when they're older. And there are back pain exercises which people can learn and can do themselves at home, and that's quite useful. And I'm putting this slide for lumbar canal stenosis mainly because as the spine ages, the vertebrae tend to collapse and the discs tend to collapse, and there is a curvature. But in the older age group, they don't usually present with a cosmetic problem until it is much later. So their symptomatology, the reason why they present is a bit different from the pediatric population. And they usually present because of pain. And pain can be mechanical back pain, as we have discussed just now, or it can be neurological back pain, because as the spine ages, you can get slips and you can get canal stenosis, which then causes nerve pain. And especially in scoliosis, as we'll come to later, you can have a slip of the vertebrae, not just in the sagittal plane forwards, but also axially and in the coronal plane, where the vertebrae tend to listhese, and that can give you some neurological impingement as well. So the majority of population will come with back pain, and they can come with claudication. Sometimes they will have leg pain and weakness. And again, the treatment initially is always conservative with tablets, analgesics, and exercise, and sometimes injections are very useful to control the pain. Operative treatment is mainly to decompress the neurological elements, and sometimes and often to also fuse them, because fusion techniques in the elderly are very useful, which we'll come to, because once you have the development of instability and scoliosis, then a decompression tends to increase that instability. So every time that we see a patient, especially an older age group patient who has back pain and stenosis symptoms, then we should always do an X-ray to look at the alignment of the spine in both planes. Because frequently somebody can have a degenerative collapse of the lumbar spine in the coronal and the sagittal planes. And the tilting and shifting of the vertebrae tends to impinge upon the nerve roots, as you can see on this particular MRI scan. So we've discussed the problems of aging, and we know that all of us age, and as we age, in our 30s, we tend to have some disc degeneration, and there can be some MRI changes that we have seen in research, but usually we are okay, apart from having 1 or 2 episodes of back pain as we are in our 4th decade. In our 5th and 6th decades, we tend to get some facet arthritis, and the discs tend to be a bit collapsed, which is again a normal process of aging, because the aim of aging, or what we hope to achieve at the end of aging, is to have a spine which may not be as flexible, but it is stable. But sometimes the degeneration of the discs and the muscles and the facets and the vertebrae themselves is unfavorable, and that's when you get stenosis and you get spondylolisthesis and deformity or scoliosis. And that's when you get adult scoliosis. So on the left side, there are some examples of somebody in their 6th or 7th or 8th decades, and their spine shows some disc degeneration, but their spine is essentially stable, and the scoliosis is not a great degree. And for these people, the cosmesis is not really a problem. But when there is a collapse and it's an unfavorable degeneration, then they get a bigger scoliosis with a shift of the vertebrae in the coronal plane as well as in the sagittal planes, and they get problems with neurology. In the older age group, like I said, they are not as worried about the alignment in the corona as you look at them from the front. but they're mainly also concerned and symptomatic from how the alignment is in the sagittal plane. Because as we grow older, to be able to stand normally, we need for the center of gravity to pass through our pelvis and between our feet, which is the most ergonomic way of standing. And a lot of research has gone into what this means, and we have discussed various orientation of the pelvis in different people, and that tends to remain the same throughout life, with various studies by Pierre Rosalie and Duval Beaupre. But in people who tend to have a problem with positive sagittal balance, the only way they can stand upright is to flex the hips and the knees to keep their center of gravity passing between the feet. And this is a very difficult stance to maintain for a long time because you are using your muscles of your legs and your back. Because if you were to stand normally, you would be leaning forwards. And this is, again, a very difficult position to maintain. And which is why in the older age group, people will come to you with symptoms of back pain, and then it becomes important to understand if this is postural back pain or is this back pain because of usually neurological impingement. So the concept of flatback is a few years old now, and we saw it in our earlier fusions, where the loss of lordosis in the lumbar spine would make it very hard for somebody who was getting more and more kyphotic in the thoracic spine in later years to be able to maintain a balance. And they would have to use most of their back muscles all the time, firing, so that they could maintain their position against gravity. So a positive sagittal balance is usually the reason why they seek treatment because of back pain. And the stooping forward is hard because your muscles in the back have to work harder. It is difficult to do activities that people have difficulty, for example, leaning, reaching the top shelves and walking any fair distance. And that can be really quite difficult. And people have to usually require a walking aid, which can also be something which bothers them quite a bit. So in the aging spine, how do they normally present? There is a collapse of the vertebrae, there is a loss of lordosis, your muscles in your legs and your lower back tend to become painful, and you get stenosis, not just because of movement or because of facet arthritis and a narrowing of the canal. The aim is to try to treat them so that they can stand upright, and that is a position of comfort. So when we look at people who are older, who have scoliosis, we look at them from the coronal plane because they can be unbalanced to one side, and they find that they're leaning to one side or the other. And they usually also have a sagittal imbalance, where they are unable to maintain the posture for a longish while. And initially they can be compensated, but over time they tend to become decompensated because the aging process tends to continue despite our best efforts. So this is an example of an adult onset scoliosis, where this patient did not have a scoliosis in childhood or early adulthood, but with wear and tear, there is asymmetric collapse of the discs, and there is some rotation, not a lot, but there is some rotation happening at multiple levels, resulting in a scoliosis. At this point in time, there is pain because the spine itself is not stable. So when they get up from the bed and they first stand up, there is a concertina effect where the spine tends to collapse onto itself, and this gives you mechanical pain. And if there is a lot of degeneration on one side or the other, they tend to get symptoms because of nerve irritation. So this is an example of somebody who has had idiopathic scoliosis as a child and as an adolescent, and as they grow older, it can become worse. And as Dr. Xu was saying, a curve which has its apex lower down tends to be harder to manage because the amount of shift of the trunk to one side is usually worse, and somebody with a lumbar curve tends to degenerate further. And at the apex, the vertebrae tend to rotate out as well as translate, and that can be quite disabling. So similar examples, you see somebody with scoliosis, they feel shortened, the trunk is shifted to the side, they usually have to use a walking stick. And when you speak to them in detail, you find that the main problem is that they are stooped forward. And on this X-ray, you can see the pelvis appears to be retroverted because they're trying very hard to maintain their balance and their center of gravity. So we come back to this MRI scan here. And on this scan, you can see that there is wear and tear of the discs. There are some modic changes, and these themselves cause pain. And there is complete loss of lumbar lordosis. So you assume that when they stand up, they are certainly stooped forward. And in the coronal plane, there is rotation as well as translation of the apical vertebrae, which is again something which is seen more commonly in the adult onset scoliosis or in the elderly than in the adolescents. And this can give you neurological impingement. Now, the impingement can be on both sides, not just what you would think is the concave side, but on both sides, because with a coronal tilt also comes rotation, and the foramen through which the nerves pass can be quite stenotic. So how do we treat these patients? So on this particular X-ray, pardon the poor quality, with somebody who is scoliotic because of degeneration, they are turned to one side, but they also are stooped over. And a corrective surgery to straighten up the scoliosis tends to help them. And the first step is to see which ones require surgery. Most patients, as we have spoken about before, should be treated for what they present with. If it is back pain, then they should have conservative treatment and they should have exercises. They may need a pain relief. They may need a walking aid. If they have neurological impingement, then that should be picked up and diagnosed as separate from the spine osteoarthritis, so to speak, and treat them. But if we are to do any intervention to somebody who has back pain, becomes very important to make sure there is no scoliosis, because if you are to intervene with somebody who has an unstable spine or an unstable or an unfavorable degeneration, you can easily make them worse. So the situations in which we are expected to intervene are people with either neurological impingement or neurological impingement as well as instability and deformity, both. Now, it is slightly easier to treat people who have a deformity which is very symptomatic as well as neurological impingement, because then you know what you're going to treat. But the risk factor of treating somebody only with neurological impingement is that we might actually make them worse, which is why for all patients in our practice who come in with, say, lumbar canal stenosis, and especially if they are in the older age group, full-length standing X-rays of the entire spine are quite important. For the same reason we spoke about earlier, a full spine X-ray, including the pelvis in both planes, and an EOS scan as well, can be very useful to identify when the alignment is off-center. Because if you were to decompress somebody who has a curvature in the spine, and they have, say, for example, you have this person who has L4-5 stenosis, and the treatment for that you would think would be a decompression. But in the older age group, we know we can make them more unstable by removing bone and ligaments. Therefore, we should then think about doing a fusion because they have a better outcome, better quality of life. When we think about doing a fusion, we look at the X-ray again, because if you were to fuse just this bit, you are not really treating the apex of the curve, which lies proximal to it. You are not treating the curve here. And therefore, if you were to do a limited surgery, they would probably in the longer term be more disabled because the scoliosis would progress. which is why in patients who have a combination of deformity and other impingement, it is usually important to incorporate the deformity into your surgery. So why do surgery? Now, you do surgery for people who have pain and disability, and they have failed treatment with exercises and analgesics. Because the people who do have adult onset scoliosis, their pain can be too much, the disability can be unacceptable, in which case we then look at the risk-benefit ratio, and that is quite important. Because somebody who is having a poor quality of life and is losing their independence and are unable to do the activities that they would expect to do at their age group, it can be very, very disabling. And this is the most important point when we see patients. So the complex spine deformities are those patients who have, for some reason or other, have neglected to have treatment, and they can present to you with quite interesting looking x-rays when they have a lot of scoliosis. And you can see that the lumbar scoliosis really progresses very greatly as they are older, and it can lead to a lot of deformity because it shifts the trunk to one side and becomes extremely disabling. And we see patients where the iliac crest actually touches the rib cage, and people have pain because of impingement of the ribs on the iliac crest, and that is again a very disabling point. And here the treatment is to restore stability and contour, and that allows them to stand up straighter, as you can see on the x-ray, and manage better. And that at this point as well, whatever impingement or neurological stenosis they have can also be corrected at the same time. Another example of, again, people who are very disabled. Now, these are people who have been managing with the walking stick, and over time it becomes unbearable. And here we talked about osteoporosis, and we have an osteoporotic fracture in the middle here, and that has obviously led to the deformity. It's at the apex of the kyphosis with a large amount of curve, and it's also leading to a little bit of lateral translation and scoliosis here. So to answer that previous question, osteoporosis can certainly contribute to scoliosis. And treatment for that is to straighten and correct the spine. Now, what are the ways in which we do that? And deformity correction surgery means that sometimes we have to restore the anterior column and stabilize it. And we can reach the anterior column by various techniques. We can do it from the back, or again, two approaches from the back. We can go directly posteriorly. We can go from the front and provide a stable base on which to then do your corrective surgery, or you can go from the side. The other thing that we can do frequently have to think about doing is osteotomy, where you actually have to take away part of the bone. You can do a 1 column or a 2 column or even a 3 column osteotomy, where you remove the apex, which is usually quite stiff, and then help to straighten the spine out. Similar examples to restore. Now, the aim of surgery, of course, is to give them good coronal alignment of the trunk in the AP view. But what really matters is to be able to restore the lumbar lordosis and even out the thoracic kyphosis so that they have a good alignment. And when they have a good alignment, then they can stand without getting tired for a prolonged period. And they can sit and they can drive. And it is something which really changes their quality of life. So which are the winners? When we talk about these complex scoliosis in the elderly people, the people who do well are the people who are very disabled at the beginning of it. And these are people who are mainly disabled because they are unable to stand up and do anything around the house. Males tend to do a little bit better. Subluxation, we talked about the translation of the vertebrae, especially at the apex. If the subluxation is more than 6 millimeters, these are the people who will respond well to surgery. And the lordosis, we talked about the amount of lordosis between 30 and 60 degrees, but people who lose a lot of lumbar lordosis, but less than 40 degrees tend to do well, because if you lose more than 40 degrees, it is quite hard to restore the lordosis surgically. And osteotomy. Osteotomy is to take away bone to realign your spine curvature, and these people do quite well. The patients who are managing reasonably well, and you'll see quite a few of them, people with scoliosis, but who are managing reasonably well, they might use a walking stick, but for their functional demands, they're managing well. And they don't have a lot of sagittal imbalance, so they're not stooped over too much. And they don't have a lot of subluxation. And they have maintained their lordosis. They don't do very well with major surgery. Therefore, we tend to avoid major surgery in such patients. And again, we come to the risk-benefit ratio. We assess each patient on their particular merits and decide whether or not they need something. There is new technology all the time, and that usually helps as well. There are various things that we can use to allow us to do these major reconstructive spinal surgeries. So we have neuromonitoring, we have navigations, we have robotic treatment, we have other instruments which help us do things like Dr. Shu showed you on the scoliosis little movie that he showed you. But the aim of all this new technology is to help you do things safely and access the areas which are hard to reach. Smaller incisions can be useful. The amount of benefit is something you look at from a case-to-case ratio, because usually people who require decompressions usually require a big incision. Robotic surgery can be more accurate, and sometimes we use it in some patients. And I think I come to the end of my talk here. So how old is old and how frail? Well, again, that comes down again to the risk-benefit ratio. The people who are terribly disabled because of their scoliosis, we assess them. We should all assess them on a case-by-case ratio. And of course, there are people who are very unfit to have major surgery. But the point is that if you work at people in a systematic manner and you find out what the goals of treatment are, then you can take somebody who is quite disabled and has a poor quality of life, and you can improve on them. Brian, do you have any input on that?
So one of the screening questions I often use in asking patients is, once you discuss all the surgery and what potential we could do and all that, I just ask the patient, do you think you're too old for this? Because I'll have patients who are 75 and 80, and I think, yeah, maybe you're too old, and they say, no, I'm not too old. I don't want to be sitting around doing nothing just yet. And then you've got the 60-something-year-old saying, oh, no, I don't think I'm ready for surgery. I don't think I'm that bad. So it's often just asking the patient and gauging where they're at is sometimes the most direct.
The other question is, do you operate in patients with severe scoliosis and osteoporosis? Well, I think the answer to that is that by the time they present in the elderly age group with scoliosis, they are usually quite osteoporotic. And osteoporosis is not a contraindication to surgery, because osteoporosis, as you know, is hard to treat, and it takes a long while for the bone density to go up. And here is when we should think bigger rather than smaller. So people who have osteoporosis, the problem is about fixation. And these are the patients where you might need to spread out the load and perform a larger instrumentation, and then therefore help them. Frequently, people who have osteoporosis are in severe pain because they've had some sort of an osteoporotic collapse or a fracture, which can be incredibly painful. And fractures tend to heal, but stabilization tends to really help their pain. So to answer that question is, no, osteoporosis is not a contraindication to surgery. Sometimes surgery can really help somebody who has got severe scoliosis and osteoporosis. It just has to be planned in such a way that you do as much as you need to do regarding the way you do it, how much correction you can do, and how much stability you need to impart.